Make sure I have everything. Welcome to today's session on maintaining independence. This is the third in a series of topics in geriatrics sponsored by the East Texas Geriatric Education Center. I'm Tony Denuzzo, director of the center, and we partner with AHEC, Texas AHEC East, very valuable in us connecting to our large service area. This is HRSA funded, and we're in our third year, and so we're looking forward to another 2 good years of funding. This is our mission. We really focus on training, providing opportunities for training and education to health providers, students, and health professions, and health professions in all levels, including medicine, nursing, health professions, School of Allied Health, as well as residents and geriatric fellows. And like I said, this is the third in the series. We're going to be focusing on health conditions and loss of independence, 3 major health conditions that are very common and are major risks for possible institutionalization, nursing home placement, as well as just that has social implications, lots of different things that we'll be hearing about. And those will include falls, incontinence, and colostomy. I do want to bring your attention to our next and last session, which will be on May 15th. We've been going around and around on topics, and we have finally solidified the topic to look at health issues among older veterans. This came about because I received some calls from the GREC group in San Antonio, and so we're going to collaborate with the UT Health Science Center in San Antonio, as well as the South Texas Veterans Healthcare System. Already have a great program in place for the 3-hour session from 12 to 3, so I hope you can make it to that. These are the topics they're going to be covering, and it should, I know they'll do a great job. There's going to be videos, time for discussion, and really understand the health needs of older veterans. In addition to that, not to get confused, May seems to be Older Veterans Health Month. We have a workshop that's going to be taking place in Waco, and this will be at the Family Health Center Auditorium, sponsored by the ETGEC, as well as the Texas AHEC East and some other groups. And they're going to be focusing on, this was a great area for the health of older veterans, since they have the areas in Killeen, and San Antonio has the VA and lots of different groups. So hopefully that'll go real well. And I want to thank our collaborators there at Baylor University, as well as the Waco region, AHEC, to help putting that together. So this is our agenda for today. I'll introduce our speakers. Rebecca Galloway will be talking on falls, Maria Camacho talking about urinary incontinence, and Mary Hill talking about fecal diversions or colostomy. There's going to be time for evaluation. We'll have a little break in the middle or so, okay? And this is the overall purpose that I mentioned earlier about this session, and that should be in your handouts if you take a look at it, as well as the objectives. Okay. We teleconference to our consortium partners that include Lamar University, that are right there. Stephen F. Austin up in the top, right? Baylor University is here at the bottom, right? Victoria College, Weatherford College in Decatur, and I think this is probably the Health Network. I'm not quite sure. So welcome, all our groups. We offer free CE credits for medicine. This is going to be available online. There are 3 major steps to get your CME credits if you plan to claim them, in terms of creating a profile, signing in, have your online evaluation, claim the credit, and then a certificate will be available to you online. To know that none of our speakers or our committee members today have any relevant commercial financial interests or affiliations to disclose. Okay. It's official. We also offer C&E credits for nurses and LVNs. It's the same disclosure Okay, and there's a sign-in sheet for that, as well as a evaluation form and a credit request form to fill out. If you have any questions about any of the paperwork, Erica can help you with that. She's outside in the table. Social work, we have CEUs available for that, 0.3 CEUs. There's a sign-in sheet for that, and there's a registration form that you just need to fill out in the general evaluation form. Okay? And as well as CEs for physical therapy and occupational therapy. Okay, again, that is the general evaluation form, and then you'll be given a letter of credit when you attend, as well as signing in, and you get all that. For those that can't make it today, this is available as a webinar, so if you're at your PC, whoever, you can join in by just getting on the URL. This is the dial-in number for questions later on that we'll have available for you, as well as the passcode. You will need to download the version of QuickTime to obtain access to the webinar at your computer. All right, our first speaker is Dr. Rebecca Galloway. I've known Rebecca for quite a while. She's been with geriatrics in the ACNN and just a super educator and clinician involved in clinical work. And she's also a member of our program planning committee for the Geriatric Education Center and runs our faculty development program in physical therapy. And she's now assistant professor and director of clinical education with the Department of Physical Therapy. And she's going to be talking about falls, risk prevention, and consequences. Okay. Are there any questions before we get started with the CE? Everything good?
Okay, well, as Tony mentioned, I've been here for quite a while in one capacity or another. A lot of my clinical experience is in acute care and in the inpatient side, but I've done a little bit with outpatient and community as well. And falls is really in itself kind of a monstrous topic. So what we're going to do is pick some things that are really relevant to all disciplines and talk about what some of the current standards of care are for screening, for interventions, from just sort of a multimodal perspective. And I'll be asking for your input as well on some of the factors, consequences in a scenario. So it's not a surprise that falls has been getting for a while a lot of attention. At state level, national level, as just a really major public health issue that's certainly not going away as we have an increasing population of older adults. And there are many, many, many different contributing factors to that. But essentially, the 1 in 3 fall a year has held pretty true for a while, and unfortunately doesn't seem to be declining. Falls are the leading cause of injury and cause a lot of subsequent health problems, not the least of which are institutionalization and the sequelae also leading to death. So we're going to come back to this case a little bit after we go through some concepts. But what I want you to keep in mind as we go through the subsequent information is that rarely do we deal with falls as this unique isolated event. Very typically with an older adult, we cycle in and out of different phases of care. And even with the same person in different phases of care can have very different reasons and contributing factors to the falls. And so I chose a case that really sort of involves an older woman who has some different pathologies and clinical issues that sort of cycle in and out and lead to then subsequent issues. And so keep this case in mind, and we'll come back to it in a little bit. So from a setting perspective, there's some differences in guidelines and sort of how we promote attention to falls as being an issue. And in the community and in the outpatient settings, a lot of the attention is on identifying those who have risk factors that are modifiable that we can do something about. And so screening. And so there are recommendations for screening to some degree, and we'll get into more detail about specifics of screening. All adults 65 and older at least once a year in some sort of a primary care setting. And then there are actually some pretty substantial toolkits that have been developed, and you have to kind of love the acronyms they come up with. So STEADY, right, is the most recent one by the CDC, and you actually have one piece of their handout with you that we'll also go over a little bit later. But if you go to the website and even just Google CDC and STEADY, you'll get numerous additional handouts if you wish to go through those. So the trivia of the day is, who knows what day National Fall Prevention Awareness Day is? Anybody?
April 6th.
But why? Why April 6th?
It was a while.
What's that? Tax day. I'll give you a hint. It has to do with a season that's relevant to our topic.
Probably winter.
It's the first day of fall. That's what they meant. So I believe that's September 22nd this year. But anyhow, look for that. It's one of the easiest ones to remember once you know the reason behind it. And so that actual day changes to coincide with the first official day of fall. On the inpatient side, something that I know has been a challenge for me from a clinical perspective is you don't quite get the same sort of, we're focused on prevention and wellness. Prevention, yes, but it doesn't have the same sort of wellness feel in the inpatient setting. But there are some guidelines in the inpatient setting for screening patients in the hospital for risk of falls, and then having some sort of a plan, although different tools are used and different things are addressed. But where the policy comes in with falls in the inpatient side, and I know many of you in the room have experience with this, is kind of from a negative perspective of if this happens, then it's sort of considered a sentinel event. A hospital-acquired condition is actually included along with some other hospital-acquired conditions that are for very different reasons. And then new this year, inpatient rehabilitation facilities will actually be required to report falls, whereas that's been an optional item in the past. So a little bit different perspectives, but it's addressed in some way in all settings. Thus far, many different tools have been tested, developed, revised, updated, and there's still not a single one universal fall risk tool. So I'm sorry that I can't provide that for you with this talk, but we will go over some examples of different things. And I think that part of the reason for that is because depending on all the many possible different factors that could place a person at risk, it becomes very difficult to then develop one thing that's going to capture that across a variety of clinical presentations and settings. So here is your time to give input on what you think as a healthcare provider about this question. If you're given the question or the statement, are falls preventable? Do you think that they're preventable? Rarely, sometimes, or usually. And so you're going to vote with your color-coded cards. Yes, so you have a yellow, a pink, and a green. So take a second to think about it and then raise them up really high so we can see what kind of responses we get. Oops. Oh. Oh, okay. Yes, I'm sorry that we did not have time to ship them the cards. so that they can't vote in the same way. But okay, don't hide them. You have to hold them up really high for me to see. So we have 1, 2, 3, 4. We have all pinks and greens. We don't have any yellows. Okay, so we're kind of split between sometimes and usually. Okay, and then if I had given you all a color option for it depends, would you? That's our students' favorite thing, is when we say the answer is it depends. Okay. So I would tend to agree you could probably make a pretty strong argument for either sometimes or usually. Anybody want to share their rationale for why they picked?
Sometimes because we haven't been able to find anything specific to prevent the fall.
Okay, so how modifiable is it in your mind, as we may not have enough evidence to know how much we can prevent it? Fair enough. And we'll actually reiterate that point here in a little bit. Anybody care to comment on usually?
If you're thinking forward about what are the risks or the causes for falls, you know, do they need assistance with standing? Are they hard-headed and refuse to call for help? But with forward thinking and planning, I think that you can minimize the risk.
Okay. I didn't put always up here because I didn't figure anybody would pick it, but does anyone in the audience have an argument for thinking that falls are always? Okay.
See how the other,
Oh, yeah. Other groups?
any of the other sites have any?
Comments from our neighboring East Texas sites?
I think most falls are preventable. If you know what causes falls and remove the risk, they will be preventable. There are some that are in the body, weak bones and muscles, that can't be prevented.
Okay.
Some will say the break in our case, like the break happens in the following break, the break happens in the fall. So,
But I recently went to the doctor and said I'm having trouble, and he found that I had a weak muscle, and he gave me exercises to strengthen it. So I'm very better.
Good. Well, very, very good points. Thank you. Okay, so that brings us to risk factors that have been found common across different settings. And so there are also some environment considerations which differ depending on whether you're in a nursing home, an acute care hospital, where we have lines and tubes to think about, or whether you're in a community where you have more environmental things to think about. But these are risk factors that are pretty consistent no matter what setting you're in, and they're fairly consistent across a variety of different studies. Any of these surprising on the list of risk factors?
I guess depression surprised me.
Okay, so what theoretically is depression linked to that could be associated with movement?
It's lack of movement.
Activity levels, participation, social things, going out. And so some of the theories are that depression, there are also some potential physiological things that happen, but just from an activity standpoint, people who have depression for a while, whether or not the depression comes first or the activity modifications come first, depression has been linked to lower levels of activity and lower levels of independence. And so I think that that's sort of your segue factor there. Good. Any others? Okay. So this puts it in a very simple context for you. This is really my summary slide of why it depends. This is the ICF model with some things interspersed based on a wide variety of different studies. So this is the standard model that the World Health Organization uses to help us understand that there are relationships between the physiological things, the activities, life participation things, and then we also have these other contextual factors to think about, some of which can be modifiable and some maybe not. And I put Gait in the center as an example. Gait gait is probably it's the most common activity that we think about being related to falls, but it's certainly not the only one. And certainly individuals who are not able to ambulate fall from the bed or the wheelchair or other things also. But this is just a kind of a typical example of we have gait issues, but then we also have, look at all of these things over here that are changing in body structure and function, and think about all of those changes that occur with aging, and then pathological things put on top of it. Right? So we know that a lot of multi-system issues decline, become more impaired from a physiological standpoint with age. And then when we put comorbidities and everything else on top of it, that really magnifies the issue. One of the things I want to point your attention to is that I'm not sure how often in the clinical realm and in studies we truly really think about other things such as confidence and the confidence to do activities and self-efficacy, and then just the actual perception about whether or not falls are okay as being a factor. I've talked with many patients who have readily admitted to me that they've had falls, but they truly feel as though that's normal and that that's a part of aging and it comes with aging. And so don't forget that even though there's a lot of research and things going on with these more physiological and activity and technical concepts, that the individual's perceptions about their potential or their problem, of whether or not they think one exists, also plays a pretty big role in this whole picture. And we'll come back to a few of those concepts. So this is not a completely exhaustive list, but if you were to ask me if I had, a minute just to observe an individual and what are things that I would take note of if they were either in the clinic or in the hospital or out shopping at the grocery store, what things indicate that this person probably has some functional problems that might very likely be associated with falls, and that, by the way, none of these are normal with aging. There are changes with aging, but all of these examples listed here needing to use an external object to balance. We call, have you heard the term furniture walker? I hear people describe, well, no, I don't need to use a cane or a walker. I just use my sofa and the wall and then this and then this, and sort of their home is strategically arranged for that. But then what happens when they're not in their home and they have to figure out where those external supports are in a different environment, sometimes in a hospital, and that becomes problematic. There's not an age at which it's actually normal to need an assistive device. I had a patient one time who was 102 who was very quick to remind me that that walkers were for old people and that did not apply to her. And she staved off using a walker until she was about 103. And then I encountered her from time to time all the way until she was 105. So at no age is it common? Yes. But at no age are any of these things actually normal. And so this one to me is kind of the trickier part. By just all these other things, you can sort of observe pretty quickly too by asking people to do simple tasks that they would do in their daily life. But sometimes it takes a little more digging to get at, okay, what they're telling me they do at home now, is that the same as what they were doing 2 weeks ago or 6 months ago or a year ago? Or have they sort of steadily but slowly given up doing things because it became difficult physically, or because they lost confidence, felt like they weren't as steady doing it, and so they sort of gave that up. But that is definitely a red flag that takes a little bit more investigating, interviewing, and talking with the person to get to know. And so those are kind of red flag screening type of things. When I find issues with that, either from self-report or from an objective observation of a patient's mobility, there are some additional tests that can be very helpful. And the way that I sort of think about examining someone's functional mobility objectively is kind of looking at all of these different domains. And so for falls, eventually, maybe not right away if there's no injury, but eventually the level of independence starts to come down a little bit, okay? And we start from having, and this is just the standard functional independence scale, independent all the way down to needing a lot of help with everything. But there's also a time in here when someone's sort of slowly transitioning from being independent to modifying things and then to really not being quite safe enough to actually needing supervision, where it really helps to have some additional information to figure out what are all those contributing factors and what can we modify and what do we need to think about testing further. And so from a functional mobility standpoint, we also look at, well, you know, what is their capacity for regular daily activities as well as maybe their exercise capacity. You know, we know that it's quite a bit to do community level activities, and so it takes a little bit more time to do something like a 6-minute walk, but it can be very telling if they start to have issues that are more obvious towards the end of a test that might exert them a little bit. Accelerometers and pedometers can be very helpful to get a sense of what usual daily activity is, and if it's low, we know that low activity places people at a higher risk of losing strength, having impaired balance, and eventually having a higher risk for falls. And then there are many, many different quality tests, and so by quality we typically will look at some aspect of the gait itself. We'll look at step length, we'll look at trunk sway, we'll look at do they need to use their hands to get up from a chair, or can they get up without using their hands? And that's another simple observation sign. When I see older adults getting up and they push with their hands, a simple thing to do is ask them, can you try that again and not use their hands? And that gives you a good sense of their strength. And that's a component of the short physical performance battery. That battery also includes gait speed and some balance measures. And the quality balance measures, typically what we do is take somebody from having a nice, stable, comfortable base of support like this to gradually narrowing it. See if they can do feet together. Okay, that's a little bit harder. See if they can put one foot in front of the other. That's even harder. And then finally see, can they balance on one leg? Because there are a lot of daily tasks for which you need to do that. Stair climbing and potentially, you know, your morning routine. Depends on how you get your clothes on and things like that, that you're often just on single limb support. And so gait speed is one we'll talk about a little bit more. Is one of my very, very favorite measures for a lot of reasons. Being a therapist for a while in acute care, was the one measure that I had time to do on every ambulatory patient. So, because it's simple, if you're gonna have to look at their walking anyway, it's not that much more complicated to carry a stopwatch while you're doing it over a fixed distance. And that's really all gait speed is knowing the time it takes them to go a set distance and then doing the math. And so this is not from one article, this is actually from several different articles, but when I put all of these gait speeds together from the different articles, you really kind of see how there's a trajectory here from having what we consider to be a normal gait speed, which is 1.2 or close to around 4 feet per second, or 1.2 meters per second, all the way to, well now if they're a little bit slower, then usually that's associated with lower activity levels or a sedentary lifestyle. But in here, when they're at this point, it's still not usually when we see a lot of disability or falls yet, okay? But if you're tracking somebody's gait speed, and you see that, oh, we're sliding down here, once you get around this point, see, there's not a lot of difference between these things. And all of a sudden you've got disability, so you've got a higher risk for falls, higher risk of mortality within 6 months, or some studies have looked at a year. And then just a tiny bit lower is recurrent falls. And so there's this, what we call this sort of subclinical window where people are slowing down a little bit, and you could detect that if you were sort of testing it at regular intervals, which is something that I often teach my patients to do, is to keep a log of what their gait speed is. So every 6 months or every year, even if they think they're doing okay, they'll kind of know. You can do the same thing with a timed up and go, and you'll see a similar sort of dose response effect with this. And then this last study down here being just ability to get up and independently walk around the hospital, which is a very different environment. It doesn't take nearly as much. And this is yours truly here in the back, his article. So this is sort of something that I use a simpler version of as an educational tool for patients, to let them know that slowing down is a clinical sign of a lot of other potentially complex problems. Okay? This doesn't tell me necessarily all the factors that are going on, but this is, to me, a good motivation for working on improving functional status to the ability of being able to walk at those faster habitual speeds, to do things independently and maintain independence in the community. And so then after looking at a lot of the physical stuff, because as physical therapists, we love to look at things and analyze things, and my husband still kind of always will nudge me when he catches me over-analyzing somebody's gait in the store or walking around on the street. He's like, well, you're analyzing that again, aren't you? But what I have come to gain a better appreciation for is that all of that stuff is important, but that the person's willingness to do the exercises and then actually incorporate their newfound strength and balance into daily activities is kind of an important thing to know. It's also kind of important to know how they perceive fall risk. And so there are some emerging studies now on looking at the relationship between those objective measures that we do. So I would do those tests and come to an assessment about whether I think the person is at increased risk for falls based on what I see. Then there are also scales and questions that you can ask patients about how confident are you with doing these different daily activities, or are you fearful of falling? And if they, so then you kind of make an assessment of, do you feel, the congruent or incongruent is basically, are you on the same page? Is their perception of their risk congruent with the healthcare provider's perception of that risk? And so you can have people who have low fall risk and high confidence that they can do what they want to do, and we call that the healthy, vibrant, great. Let's keep active and keep preventing anything else from happening. Then you also have the group that you see they're at a high risk, and they very well know that they're at a high risk, and you're pretty well on the same page. And that's sort of what people kind of call the aware group. Okay. And then you have others. And you can have others in different categories, and I think that clinically the risk takers kind of stand out. So one article that called this sort of the stoic group. They feel as though they can still They can still kind of climb that ladder and get up on the roof or whatever it is, and and that's okay to do, or that it's fine to get up and.
I'm sorry. Can we just have the other sites please mute? One of our sites needs to mute, please. Not only that, but hello.
Good. No, that's okay. Or in this group is also the people that think it's absolutely just fine to get up in the hospital when they have a Foley catheter and an IV in, and their gait is unsteady to begin with, and that they'll be just fine doing that. And then you have this group that I'm not sure has quite gotten enough attention in the literature and our clinical awareness, and that is those that objectively, from what we can observe, should be capable of doing activities that are much beyond what they feel they are capable of doing. And so what's the problem with that? Yeah, these are people that fall into this cycle of, well, then I'm going to stop doing this, and then so eventually they actually move into the congruent group, but that isn't what we want. We would actually like for them to be over here. They move into this group where eventually their fears come true and they are at a high risk for falls because they've declined functionally. My take home from this is that as a clinician and even a family member of a loved one at high risk for falls, is the kinds of patient education discussions I think need to be very different with these different groups. And we're not quite to having a lot of actual research on tailoring components of the management process while considering a congruency factor. You all can probably think of a whole lot of, where's the mouse? Oh, I need to click this, sorry. A whole lot of consequences. So obviously there's cost to individuals, cost to health insurance, cost to the community. There's the fear issues. Fear not just of falling and falling again, but fear of losing the independence, having to go to a nursing home, having to feel like you're a burden on somebody else because you're not able to safely do the things that you once were. And then caregivers, I think, too often share a kind of a guilt about, well, if I'm supposed to be involved in the care of this person, then and they fall, then what does that say about how well I was paying attention to things, as well as caregiver roles changing if somebody happens to have an injurious fall, for example, a hip fracture, and then now that caregiver goes from just being someone that maybe helped with some of the light housekeeping and grocery shopping to needing to physically assist the person with some basic daily living things. And so here's just a really short kind of 1-minute clip that I think summarizes these concerns pretty well.
I'm at that age now where things are starting to go.
And I realized that my sense of balance had gone.
I fell in my son's home. I fell down 2 steps.
Lots of my friends have fallen and get hurt,
You walk into a strange place, the lighting is poor, and it's very easy to trip and fall.
So you're apt to say, well, I'd rather stay in today. I'm not going out,
So many of us seem to feel there's no way to keep ourselves from falling except to stay at home, not take any chances, and rely more and more on the help of others. Have we decided that the cost of personal injury is so great it must be avoided at any price, even at the price of our own well-being?
And so I think that that's kind of a good question. That, you know, it makes for a really long conversation with patients and caregivers, but especially for complex cases where there are a lot of different risk factors involved, and it's you know, it's not a simple fix of, well, let's just strengthen this muscle, or we're making real lifestyle choices and choices about living situations. I think that that's a hard question to answer, but it's a really important conversation to have with patients and caregivers that are sort of going through these kinds of thoughts. And you know, they actually mentioned the words that, you know, you're making a conscious choice to change your lifestyle because of either a fear of falling or because of actual falls. But I'm not so sure it's really always an active thought process. I think a lot of times there's these more subtle transitions that happen, and then a person looks back, if you ask them what were you doing a year ago or 2 years ago, and the picture is very different. And so this sort of summarizes what tends to happen in a more cyclical fashion, and particularly to those who, you know, appear in the pathology. Could be a lot of different things, but they may have had a fall themselves, or they may have just had somebody who they knew who fell, and then that gave them a heightened awareness that they might be at risk for falls if they do something out of the ordinary, or even if they continue to do the things that they're already doing. And so this is really what we try to prevent, is the decline that leads to significant lifestyle changes. And then, because we know that there's a lot of other comorbidities, not just things related to strength and deconditioning, but limiting your physical activity then has, you know, cardiovascular risk factors increase. Risk of diabetes and all kinds of other things increase that then create new pathologies, and all the while no one's gotten younger. So you've got all those other things that sort of compile it, and so this keeps, unfortunately, going in the same sort of circle unless you can figure out, you know, how to sort of push some of these back, reverse some of the functional decline, and help them gain some independence. Exercise is proven. Now, there are varieties of types that have been studied, individualized and potentially some group, but exercise with sufficient intensity for strength and balance and gait training, for sure. Tai Chi is one that kind of combines coordination, balance, flexibility with motor control activities, has also been commonly cited as effective. The take-home message about the exercise, again, is I think with somebody who has a risk of falls, there's a tendency to want to make sure that they're safe while they're exercising. But for balance, intensity, you have to figure out a way to make the intensity high enough that they do challenge their balance a little bit, whether they're being supervised or, you know, they're near a stable surface that they can put their hand on if they need to. But if they're completely stable and steady, it's not a balance exercise. It's not difficult enough. If they're sitting down in a chair and doing exercise, but they're able to walk, it's not challenging enough for them to improve their balance. And so that's probably one of the most difficult things about prescribing exercise, is that you have to find that balance of they're safe doing it, but it's also challenging enough to improve their risk. And vitamin D is potentially related to increasing muscle strength, and involved with that process. And what the differences in studies are about whether or not it's helpful in people that don't have low levels, but studies consistently find that in people with low levels of vitamin D that is helpful. And then that's the one that you should have on the pink card that is associated with increased risk in falls, and not only just falls, but injurious falls. Everything else actually has insufficient evidence if you look at the systematic level. If you look at individual studies and select settings, some of these things do help. But for example, hip protectors, there have been a lot of issues with compliance and the feasibility of people consistently wearing those. I'll mention a couple things about assistive devices. General education, without it being tailored specific to that person's risk factors and with modification. So by itself has not been proven effective, as well as general home hazard modification. Studies have found it's helpful if that person has specific modifications that have been linked to their fall risk, but just as a general going in and doing a general home safety eval without knowing that that's going to modify anything specific to the fall risk has not been. And so this is another one that I think when you look at a systematic level, no one's going to say don't try and take away medications that could be related to a fall. But if you look at some of the issues that are associated with tapering medications, and particularly things like psychotropics and benzodiazepines that are really the most strongly associated with falls, can be challenging sometimes, depending on how long they've been using it. And so I think the study designs have just been kind of inconsistent with that. So it doesn't mean that these things aren't potentially helpful when those risk factors are identified, but when you look at a higher level of, did studies definitely conclusively find overall that these were proven interventions, there's a lot of things we're still not sure about. And I think that goes back to Bronya's earlier comment about, even though we know what a lot of the risk factors are, the jury's still out on a lot of these things about how helpful they are. But we have at least two that in numerous studies have been proven effective. Okay. And so I gave you a handout on the study, and I'll kind of walk you through a little bit of that as a summary with this case. But there are some gaps, and Cochrane has a lot of systematic reviews out on falls, and some of those gaps really are figuring out an evidence-based algorithm for truly managing multifactorial components of falls. That's still a challenge. There are a lot of gaps in the inpatient literature on things like, do bed alarms help, and toileting schedules and different things, and what tool is actually can help us project which patients are going to fall. Whereas it tends to be, well, let's just kind of throw the bucket of everything possible to prevent falls, and that, as we saw on this slide here, doesn't tend to prove to be real effective. So we have a long way to go. A couple things that I have not seen in these, for example, the study and some of these other national level recommendations that I have found clinically, just my own experience and evidence, to be really important, is it's great to focus on preventing falls, but it's also really important to empower someone and educate them about what to do if it happens, because it just might. And if it's happened once before, the odds are one of the best predictors of future falls is past falls. So these are just some of the things that I go through with my patients when I identify that they have a risk for falls is, okay, well, let's, in a controlled manner, help you down to the floor, and let's strategize how to get up. Or if you're too weak to get up, let's train your caregiver and how they're going to assist you up, or how they're going to identify whether or not they need to call EMS versus being able to get you up and maybe just getting you to the clinic for a checkup. So I just have found that spending a little bit of time on this it sort of validates that their fear is real, and that this is a possibility. And I'm not saying that this alleviates fears. When somebody falls, it's tragic, it's horrible, but they need to have some tools for what do I do next if this happens, rather than just feeling guilty and horrible and in pain that it did. And then with equipment, my rule of thumb with equipment is that I do a lot of analysis of the person's gait with and without it. And I look for something to objectively improve, or even subjectively with confidence improve, before I determine whether or not that's appropriate. And then I think it always needs to be in conjunction with addressing balance, strength, flexibility issues that occur in conjunction with needing a device. So if the cane makes their gait look better, great. But don't give them a cane just to say you did something about their gait problem. Some people walk worse with a cane than they do without it. It takes a lot of coordination. When you give someone a device, it takes more energy for them to walk. And it actually, if used improperly, can make things worse. And so this is one of those, prescribe with caution. And ask too, if somebody brings in a device to the clinic, it doesn't necessarily mean a healthcare provider prescribed it. There's a whole lot of, you can usually tell if the height is way off or something like that. But that's a telltale sign. So what I want you to think about, this is our last slide, is going back to this case and looking at your study handout. And I could put that, well, let's go over this first. So this is a patient who, 68-year-old female, who for a while is doing fine. Community level, is working as a substitute teacher and playing with grandkids and kind of doing what she wants to do, and really all she has is arthritis, right? But she has had one fall in the past year, and then she has this sort of acute illness on top of it, where she gets cancer and then needs 6 months of chemo, a little bit of radiation, subsequently develops hypertension, and then is healing and in remission and all of that, but develops some neuropathy. Okay, so knowing all that, keeping all that in mind, I want you to kind of look at the handout I gave you. Put this up for those who might not have it at the other sites. Just skim that, look at some of the risk assessment things, look at some of the intervention things, and kind of just tell me from your perspective what you feel like your role would be, or what you would check for or ask. And as soon as you have a thought, you can go ahead and share it. Could be something not on that algorithm too, if you think of something else.
I think I would want to know what it is she's trying to do, that's when she's falling, what the circumstances are, and then we can do some education from that perspective.
Okay, if I need to repeat, do I need to repeat that for the other site? So Patty's comment was about the circumstance of the fall, when it's happening. Yes, so things about time of day, activity, really, really important to know. And so typically this is with walking and with turns very often, with changing direction was when most of them happened, but not all, but the majority of them with turning and gait.
I think I'd be interested in what avenue they're receiving their rehab through.
Okay.
Are they using home health or an outpatient clinic or a residential rehab?
Yes, and so this ended up being an inpatient rehab and then transitioned to outpatient care. And so falls were a focus in both settings. In the inpatient side, it was more of just preventing, asking for assistance because we're too weak. And then in the outpatient, the emphasis is more on actual modification of or interventions targeted at specific impairments to reduce fall risk and safety. but safety then in a different setting. So safety in, you know, as she alluded to as well, more questions about, well, what are the environmental circumstances that you're going to encounter at home, but not just at home, also in the community. So if she's a teacher, I want to know things about, well, do you have to go up and down stairs in a school, or across, you know, across lawns, where you do your grocery shopping? Do you have any trouble reaching for things and grabbing objects, or do you need help with that? Good. Other comments? So with the hypertension and then the neuropathy, what's the issue with the hypertension? Is that going to be a problem at all, or something you need to assess? So I hear medications, right? So if she's on medications, is her blood pressure stable, or is she having episodes of hypotension? So that's a legitimate question, especially when it's a new condition and the medications might be changing. What about the neuropathy? How many things is that going to impact? So, and I put it here, this is lower extremity distal neuropathy. So sensation loss, impaired sensation, and motor weakness in the ankles, the feet. Okay, so that really can change a lot of the sensory processing, and then the ability to actually respond to and maintain balance should something unexpected happen. Okay. So sort of my point with this is really not simple. There are a whole lot of different things, and then don't forget, arthritis hasn't necessarily gotten better throughout this whole process. So then there's pain issues, weakness there. And so lots of strengthening, addressing, well, how do we compensate for the sensation loss? You know, would a cane or something like that be helpful? We need to do a lot of assessment on that. And then really considering the environmental things to target, what does the rest of the assessment need to look like? And what do we need to, in terms of gait training and balance training, prepare this individual for when she encounters things at home and in the community? So other comments or questions on sort of putting that all together? That's all I have.
I got a question, and it's like you had mentioned that it's when they're changing direction. So what is it specifically that we could help with that?
Balance training does help with that, and gait training, but so incorporating those changes and watching how they do it, because you have to use proprioception and vision and motor control with turns. And so if you watch somebody turn and they start needing to take shorter, slow steps rather than being able to do this direction, you can actually work on strengthening and balance activities that incorporate turns and work on those as actual activities. So typically when we do targeted interventions with strength, balance, flexibility, you don't want to just do them isolated. You want to work on something and then actually put it back into a task. So very often it's most helpful to have them practice with your feedback the activity that is unfortunately more fearful for them. Does that answer your question?
Don't you have to look at also the chemotherapy that she's undergone?
Yes.
And how the nutrition is?
Nutrition is, exactly, because, and that was a factor in this case, is that overall caloric intake was down, but then protein intake is down, and then you have issues with maintaining muscle strength and weakness, and that's where some of this deconditioning came in as well acutely, was because of the chemotherapy, and then higher risk of infection after that. So simple things like a urinary tract infection can then compound everything as well. So yeah, so the chemotherapy is absolutely an important part that's going to affect all of the body systems. The neuropathy was actually a sequela of the chemotherapy. Yeah. Good. Well, thank you. Are there anything else from the other sites for wrap up?
Questions or comments from the other sites as well as in here? We have one more.
I just thought we'd ought to know about how you feel like, what does she feel like she is going to be able to accomplish. If she tells you, I've got to hurry up and get over all of this because I need to be back in the classroom on August 15th.
Yes. No, that's a really, really good point. And, you know, often, too, not everyone has the luxury of being able to stop working or doing things that might be very physically difficult for them. And so that was something that we considered in this case, particularly with the assistive device prescriptions. We ended up doing as you know, gait training using the cane really only for you know, uneven terrain and in the school and in other areas. And one of the things that she mentioned with the cane was that she didn't so much feel like she always needed it in the school environment, but that it was kids around. She said it was a great visual cue for the kids to recognize that and remember that, hey, they needed to be careful and not run into her and bump into her. And so that was also a factor in sort of deciding what's going to be the best for that equipment prescription. But I completely agree with you. The goals is pretty much what everything has to be centered around, and the intervention is obtaining those. Okay, thank you.
Thank you very much. Being here, and we're here for our third lecture. I'm really pleased to introduce Mary Hill, who is with Nursing Administration Adult Patient Care Services, specializes in wound care and ostomies and continence. And there's her bio. She's recently here from UTMB, and she can tell a little more about herself if she'd like. There's lots of things I like her. Passion of providing care and improving quality of life for those dealing with life-changing fecal and urinary diversions, chronic wounds, and prevention of skin issues, which obviously are real important for older patients.
Thank you. Well, thank you everyone for having me here today. Branya, our wonderful